Hello everyone, welcome to ANAT AV. In this video, we will be discussing about the patella, which is also known as the kneecap. The patella is the largest sesamoid bone in the body. It is embedded in the tendon of the quadriceps femoris muscle, lying anterior to the femoral condyles. The tendons of rectus femoris and the three vastus muscles, lateralis, intermedius, and medialis, converge to form the quadriceps tendon. Look at this patella on the horizontal surface. The patella is a flat triangular bone. It is distally tapered and proximally curved and has two surfaces, anterior and posterior, three borders, superior, lateral and medial, and an apex, which is at the distal end of the bone.
Let's look at the side determination of the patella. Apex facing downwards and base facing upwards. Anterior surface is rough. Posterior surface in its upper 3/4 is smooth. Let's see how we can differentiate between the right and left patella. The bone laid down on a horizontal surface lies on the broad lateral surface, and the larger facet among the two is the lateral facet. So the right patella can be easily distinguished from the left patella.
Let's look at the borders. Superior border of the bone provides insertion to the rectus femoris in front and to the vastus intermedius behind. Lateral border provides insertion to the vastus lateralis. Medial border provides insertion to the vastus medialis. Let's take a look at the surfaces. Anterior surface is rough and non-articular. It is covered by the quadriceps tendon. Upper 3/4 of the posterior surface are smooth and articular. This surface has a vertical ridge dividing it into a narrow medial area and a broader lateral area. The narrow medial surface is further divided into two vertical strips. The most medial facet is in contact with the medial femoral condyle only during knee flexion. The larger lateral facet is in contact with the lateral condyle throughout all phases of knee joint movement. The non-articular area on the posterior surface and the inferior border is attached to the smooth convexity on the tibial tuberosity via the patellar ligament. This represents the continuation of the quadriceps tendon. The roughened apex is directed downwards. It is also attached to the patellar ligament. Patella retinicula are fibrous expansions from the quadriceps tendon and patellar ligament which connect the sides of the patella with condyles of the tibia and collateral ligaments. The lateral retinicula are reinforced by the iliotibial tract. In the subcutaneous tissue of the patella and the patellar ligament, a plexus of nerves known as the patellar plexus can be seen. Arterial supply to the patella is derived from the genicular anastomosis.
The patella is mobile from side to side. The patellar ligament is vertical, but the pull of the quadriceps is oblique. So, when the muscle contracts, it tends to draw the patella laterally. Three factors discourage this tendency of the patella to dislocate laterally and therefore maintain its stability. Bony factor. That's the forward prominence of the lateral condyle of the femur. Ligamentous factor. That's the tension of the medial patellar retinaculum. Muscular factor. The lowest fibers of the vastus medialis are inserted almost horizontally into the medial border of the bone. Hold the patella medially when the quadriceps contracts. They are indispensable towards the stability of the bone. Recurrent dissolution of the patella occurs if the lateral condyle of the femur is underdeveloped or if there is considerable genu valgum. Following complete excision of the patella, knee function and movement may return to near 100% efficiency.
That brings to an end this video on the anatomy of the patella. If you enjoyed this video and found it helpful, don't forget to like, comment and subscribe. Please share this with your friends and anyone interested in the study of anatomy as a subject. Thank you for watching ANAT AV.